of ECMO circuits. Professor Coombs, please.
Thank you so much. There is probably a technical problem with the slides before, so I will go ahead rapidly to the second part of the talk. Just a few words about the peripheral cannulation with a surgical cut down, which will be discussed by Dr. Stark. It has been used for years until, for us, the mid 2010 at a date we decided to switch to the percutaneous approach, and these are the main reason why we decided to go to this approach using the cell digger technique. This is very important here, that there is only one puncture of the vessel, no puncture of the posterior wall of the vessel as well, and also very importantly, the use of ultrasound guidance here to make sure, first, that you do not puncture the posterior wall of the vessel, second, that you see the progression of the guide wire within the vessel, especially true for the vein here, to make sure that there is no aberrant location of the cannula, like here in the contralateral vein, which is not a major issue, but this may be a major issue when you have the guide wire going in the hepatic vein, like it's the case here. So ultrasound guidance is very important at the time of cannulation. It's going to improve the outcome of the patients because, first, the percutaneous approach will decrease the potential infectious complications and bleeding events by making sure that you will puncture the right vessel and just with one puncture, and also to make sure that the progression with the guide wire is completely adequate. So this is now the setting we use for most of our VA patients. You can see here the drainage from the left side, in which the cannula is inserted into the femoral vein, which goes into the IVC2 positioning of the tip within the right atrium, and the blood is reinjected most frequently on the other side. And here you can see also the reperfusion line, which is positioned through the superficial femoral artery here. And in that patients, we also have a balloon pump. This is our strategy here in Paris, to use a balloon pump to prevent pulmonary edema and to decrease the LV and diastolic pressure. So there's been a few studies conducted in the last decade evaluating the impact of the percutaneous cannulation. This is a first work from the team in New York City and Columbia University, when they used two types of setting, especially regarding the size of the return cannula, the arterial cannula. And during the second period, they used a smaller cannula, 15 French instead of 17 to 24. And doing that, they use most frequently cannulation at the bedside, for sure, using the percutaneous technique. You see was 88% in the second part of the experience, was only 43% initially. And with smaller cannulas, of course, it got lower blood flow, but patients under VA does not need 5-6 liters of blood flow. Usually it's between 2.5 and 3.5 liters of blood flow. So with a 15 French, it's for most patients much enough. And they got less bleeding at the cannula insertion site, also less general bleeding here, with no difference in mortality in this series of 100 patients. This is the publication of our results here in Paris. At the time, we decided to switch from a purely surgical approach. It was roughly in 2014, 2015 that we decided to switch from the surgical approach to the percutaneous approach, and we retrospectively evaluated the outcome of the patients. It was 485 surgical versus 329 percutaneous, and we also matched cases and control to define pairs of patients, 266 surgical and 266 as well percutaneous. So these are the characteristics of the patients. The size of the arterial cannula decreased in the second period, and it was just the same as the report from the group from Colombia. No difference in the venous cannula. There was a little bit less of reperfusion lines inserted here, although the difference is very minimal. Also, we use more frequently contralateral venous cannulation for these patients was 19 versus 47. And there was no other major differences in the characteristics of the patients. This is here the major results. There was no difference in the 30-day overall survival of the whole cohort of patients, but still less infections, and this was highly significant, was 27 in the surgical group and only 14 in the percutaneous. There was a trend also towards more vascular complication after cannula removal for patients in the percutaneous group, and it was mostly linked to surgical revision for persistent bleeding after cannula removal. At that time, there was only compression of the groin, which was used, and we now have a strategy using a closing device, the MANTA device, which probably will fix many of these issues. No difference in limb ischemia between the two groups, which is also very important here. And this is now the outcomes in the propensity match cohort of patients, 266 patients in both groups, and the survival rate actually after controlling for confounders was higher for those patients who received the percutaneous approach. It was quite a surprise for us. We were quite convinced that we probably would be less infections, but also after controlling for confounder, there was less deaths in those who received the percutaneous approach, and was significant here. Also, less infections for sure, less infections requiring surgical revision. No difference in the rate of vascular complication at cannulation or limb sensitivity motor deficit. These are the results here in the propensity matched cohort of patients, which basically showed the same information. Now, we also evaluated the factors associated with infection at the cannula insertion site, and the percutaneous approach was highly protective. And those factors associated with infections were chronic heart failure patients, and of course, the duration of support. The longer the duration of support, the higher the probability of getting infections at the cannula insertion site. The factor associated with limb ischemia was only the initial SOFA score, and probably also linked to the need for more vasopressors in those patients with very severe disease and multiple organ failure. This is here the Kaplan-Meier curve for the adjusted and unadjusted probability of surviving. And as you can see, with the adjusted numbers, there was a highly significant difference between the two curves, and a benefit for those patients who got the percutaneous approach. So in conclusion, the percutaneous cannulation for peripheral VA is clearly less invasive, uses smaller cannulas, but the blood flow you can get is perfectly adequate for VA support. It's major advantages, especially if you're local infections. The rates of ischemia or motor deficits is just the same. Improved 30-day survival, probably because of less complications. And in that series of patients, a higher rate of vascular complications following decannulation, mainly because of persistent bleeding, also some more late complication, but this might be majorly improved by the use of closing devices. And this is my last slide, a tribute to my team, which did a lot of work during the past 14 months with those severe COVID patients, still a lot here in France at the present time. Thank you very much for your attention.
Thank you very much. And now we switch to Professor Stock for the cons, please.
Yeah, thank you very much. And it's always good to look into the program before you start preparing your presentation, because I wasn't aware that Alain is going to be my competitor, kind of. So if I get my first slide, as you will see, we have a similar approach.